Hi, everyone. Hi. Welcome, and thanks a lot to all of you for attending this session today. So today we are going to talk about mental health, smartphone apps, and the promise of artificial intelligence. We'll have about 15 to 20 minutes, an hour and 15 minutes, sorry, to talk about this topic. Just as a quick reminder, if you want to ask any questions, you can do that online. So by connecting through your WMIF mobile app, you go to the agenda and through this session, and you can click on live Q&As. So basically, this will push your questions to our moderator. And so, talking about our moderator, it's my great pleasure to introduce Sabine Wilhelm. Sabine is our Chief of Psychology at MGH. She's also the Director of the OCD and Related Disorders Program at MGH and Professor at Harvard Medical School. So Sabine, the floor is yours.
Thank you so much for the introduction, Emily. So I'd like to welcome you to our Discovery Cafe on mental health, smartphone apps, and the promise of AI. And just to provide a little bit of context, about 1 of 5 adults in the United States, so that's over 43 million people, experience mental illness in any given year. And about half of all chronic mental illness begins by the age of 14. So there are a lot of people who are suffering out there, and many of them get sick when they're really young. And unfortunately, most people with mental illness do not receive any care at all. And even when they do, they often don't receive good care. As a matter of fact, when you look at all of the people with psychiatric diagnosis, only a small percentage of people with psychiatric diagnosis, only about 15%, get appropriate mental health care. And that's because there's so many challenges that people are facing when they're seeking high-quality care, such as the lack of appropriately trained providers, or the fact that even when patients are finding providers, they are often not completing assessments that are detailed enough or that are frequent enough in order to inform the most helpful treatment plan. And then there are all kinds of other issues for the patients as well. Because in order to find a provider in a timely fashion, the patients are often facing very high costs. As a matter of fact, I went on to Psychology Today just last night to see what the going rate is. And here in the Boston area, I mean, it's almost impossible to find a provider who charges less than $200 per session. And frankly, most providers are charging $400, $450 or so. So many people can actually not afford that. And let's say, even if you have found a provider, then you deal with other issues as well, right? You have to make the time in order to get there. Treatment sessions are usually once a week. You have to park. You have to have transportation in order to get to that provider's office. If you have kids, you have to have childcare so that you can make time for your treatment sessions. And today, I'm really excited that we have assembled this wonderful panel to talk about solutions that AI-enabled technologies might be able to provide to help our patients overcome these challenges. So it's a real pleasure to introduce our panel. I'm going to start with you here, with Jennifer Gentile. And Jennifer is the Senior Vice President of U.S. Clinical Operations of Ieso Digital Health. And right there's actually Tom McCoy, and he's a Director of Research for the Center of Quantitative Health, and he's an Assistant Professor of Psychiatry and Medicine at Harvard Medical School. So that's Tom. And then we have Chris Molaro right there, and Chris is the CEO of Neuroflow. And then the far left right there we have David Silbersweig. He is the chairman of the Department of Psychiatry at Brigham and Women's Hospital, and he's also a Stanley Cobb Professor of Psychiatry at Harvard Medical School. And last but not least, right here, there's Jeremy Sun, and he's the Vice President and Head of Business Development and Licensing at Novartis. So I'm very excited to have you all here, and I'm going to get us started right away with our first question. And I have some questions here, by the way, that I want to ask, but you also have the option to send me questions via this app right here. So I will also see the questions that you are submitting via the app. But let me get you started with which challenges in mental health, in your opinion, seem most ripe for the use of AI-based tools? And anybody can answer, so feel free to take any question that you'd like to speak to. Yeah, Jennifer.
I'd like to start with the first would be access. So a very basic challenge, not thinking about what the quality of care. So first step would be access, and the next step would be quality of care.
Mm-hmm. Okay.
So I might say real-time, real-world monitoring with appropriate feedback back to the patient.
Mm-hmm. Okay, so assessment, monitoring.
Yeah, I think it comes down to being able to know what type of treatment is appropriate at the right time to kind of build on that. I have very personal experience being in the Army, and coming from that world, had a soldier that was being seen for chronic pain and was also diagnosed with depression. And he was referred to a specialist, to a psychiatrist, and 3 months later, he ended up losing his battle and died by suicide. And we investigated what happened, and it turned out not once in those 3 months did he follow up and go see the psychiatrist. Not once did the primary care provider and the pain management doctor follow up and ask, how's your depression doing? And so if we had AI tools there to be able to understand that soldier wasn't on the right track, and we could have been proactive in reaching out to him, I think it could have been saved his life.
We'll talk about this more, I hope, but Novartis has been one of the first pharma companies to help bring to market the first commercial FDA-approved product around substance use disorder and opiate addiction. And so AI is built into those technologies, into those drugs. It is a drug that is an application. And so, happy to go into more detail as we talk about the talk to the panel, but very briefly, the AI component behind it is that it is a living, unlike most drugs, which are fixed in the compound itself, right? Whether it's a pill or an injection or infusion, these are fixed drugs. In a digital therapeutic, by nature, these are ever-evolving drugs. And so we use AI to better determine what intervention do they need, when do they need it, how do they need it, how do we create other behavioral motivation and incentives and responses to be able to address the triggers in real time. And so AI is a very useful tool for us in that particular therapeutic agent.
Mm-hmm.
I'm most excited about tolerability. I think as a prescriber, we've made more strides in tolerability over the last 40 years than we have in efficacy. But so much of our risk stratification and precision medicine story is around efficacy. Mm-hmm. I think there's a lot of work to be done in predicting tolerability, which is really just part of access and adherence.
So lots of wonderful suggestions how AI-based tools might be used in helping patients get access, timely access, personalized access for the problems that they're facing. And I think it's increasingly important to also understand how assessment might be able to help us tailor treatments as well. I think you were starting to hint at that a little bit, David. Do you want to say just a little bit more in terms of how perhaps smartphone-based assessments might ultimately help us tailor our treatments better for our patients?
Sure.
Just elaborate on that.
Sure, Sabine. If one pulls all the way back, one has to ask assessment of what? Mm-hmm. And our field is undergoing, I think, a remarkable and important sort of evolution in terms of the taxonomy of these disorders, a defining of them that is based in description and subjective report, but then starts to be supplemented more and more by objective data and by measurement and quantification. And so, and the chips may fall in different places in terms of what the particular syndromes are and how they're treated. In terms of assessment in the real world, or assessment in how these sort of approaches can help, many of these diseases, especially the more severe ones, a symptom of the illness is to not think you have an illness. And that itself, the lack of insight, is something that is a tremendous barrier, especially as patients spin out of control or get more ill. And so there's the initial assessment diagnostically, and I think in the future that is going to start to have more objective behavioral quantification, whether that is with actigraphy, with sleep, with voice and face, emotional measurements, if you will, with the patient's permission, with social media usage and spending and all of those things, which then can correlate with, or even where they are within the house or outside of the house, et cetera, how withdrawn, how psychomotor retarded, et cetera. And then if one's thinking about assessment longitudinally and tailoring to the patient with appropriate AI backend, one only needs to think of a patient with bipolar or manic depressive disorder. If I'm going to see him or her next week or in 3 weeks from now, but if there is an app or a series of passive HIPAA-compliant, digitally quantifiable measurements that tell me that the patient is having 375 times their usual spending on their credit card, 2 hours of sleep a night, a lot more activity in terms of where their social media usage is, where they're running around to, then with an appropriate algorithm to detect that, to flag that, to send that to me or our care team, then we can contact the patient and say, you know what, how are you feeling? Either, you may want to increase your medicine or whatever, or come in and see us before the 3 weeks, et cetera. So it's really the full loop, and the AI is the back end between all of the passive sensing, the crunching of the numbers, and then feedback to the patient and the clinicians, either by virtue of these dashboards and or digitalized therapeutics that can then go directly to the patient when and where they need it in a way that's tailored to them.
Yeah, that keeps coming up as a very important next step that I think we all have to take, which is these risk-based assessments, right? So that we know when a patient is struggling, when a patient is at risk, and at that time we are able to deliver a targeted intervention. I agree that's one of the most exciting developments that we have seen and that we will see more in the future. I want to get back to the access point that you made, Jennifer. Can you elaborate a little bit on that? How do you think these tools will help us overcome the mental health treatment gap?
Sure. So telehealth, so seeking care not via in a bricks and mortar practice, can help with the access problem. We know that studies have shown over and over again, people don't get care because of lack of access to providers, lack of availability to the providers who are in their area, transportation costs, stigma, and other just payment for services. So AI is a way to surmount that, AI via telehealth, to figure out how to provide that care in a way that's not one patient to one provider interaction. How can we collate all of the information gleaned from thousands of providers, which we've done at Ieso Digital Health, and then provide that information to that therapist so he or she can provide that highest quality care and provide that access, have shorter treatment durations, have more targeted, right pace, right patient, right dose, right time of that care, and ensure that the care is evidence-based. It's not just access to somebody checking in with you to say, hey, how's it going? It needs to be based on what the research tells us that makes patients better over the long term.
Mm-hmm. And so we've talked a lot about the wonderful tools or the wonderful characteristics of those tools. What do you think the downsides might be? What are the challenges? What are the risks?
From my perspective, there's some positives and there's negatives. So, I mean, in terms of, let's just thinking about digital therapeutics as an example, as a starting point, and that's mostly my reference. The good side is that when you look at, I don't want to suggest that there aren't adverse events, but when you look at the adverse event profile for a lot of the digital therapeutics that we've been evaluating in neuroscience, and in particular substance use disorder, to opiate addiction, to MS, to schizophrenia, is what we're not seeing right now is we're seeing what I would say is a fewer side effects. So you're not seeing sort of the chemical-based side effects that you would normally see, liver toxicity, atrial fibrillation, QT prolongation, some of the typical side effects that you might see from traditional drugs. So in that context, it's actually warming in the context of that we could deliver potentially a best-in-class therapeutic without having to worry about the normal body response to these agents. I want to be clear, though, there is a chemical response, right? So from a pharma perspective, it's very important to us that we could actually map mechanism of action and that we could actually see the neuroplasticity, the neural response to this. So it's not that physiological responses aren't taking place, it's just that they're not necessarily, you don't see the residual effect of those drugs as they're going through your biologic system. Other risks I think is that we begin to, again, in terms of sort of access, is that we are afraid to actually embrace or adopt those risks. This is what we're seeing actually in the early stages right now around digital therapeutics. A lot of times, and I was careful to emphasize that it is a drug, a lot of times we're afraid to actually say that these are drugs. These are drugs. They're followed the exact same regulatory pathways, the rigorous requirements to do clinical trials as any other drug. And so, the biggest risk that I see quite candidly right now is the fact that it takes 7 to 10 years to change physician behavior. We're doing a lot of education even within our own ranks, within the pharma industry, within our sales force, to just educate people that there's no difference. Again, a drug, an injection, cell and gene therapy, these are all accepted. They're all novel, cell and gene therapy is brand new, but I don't have to explain to someone that cell and gene therapy is a drug. I do oftentimes have to explain to someone that digital therapeutic is a drug. So we need to get over some of those risk-adverse responses.
Okay, David?
Yeah, I guess I'm not risk-averse at all, although I would question whether it's a drug. But that's with all due respect and for the purpose of discussion. I think it's a therapeutic for sure. And I think all sorts of things, including cognitive behavioral therapy, modulate the brain, and video games, modulate our reward system, et cetera. But I do think it's more than semantics, but maybe that's a topic for another day. I think, back to your question, Sabine, confidentiality in this day and age. We deal with often the most personal aspects, and while many, including many in the younger generation, may feel more comfortable sharing all sorts of things, we see time and again that health information, especially the farther it goes out, can be hacked, and that there are nefarious, folks, who have ulterior interests. So I think that's another thing to consider.
Yeah, actually, our audience members have also commented on that, especially in other countries where ideas about security might be even looser than what we are considering to be the standard here. But even here, I find that app developers and perhaps even clinicians who are currently recommending apps to their patients are often not thinking enough about security. And I have been increasingly concerned about the apps that I'm recommending to my patients, because you really want to think about what kind of data are being collected and how they're being stored. And especially if you are using a free app, are those data ultimately going to be sold to third parties? So I agree with you, and our audience members have also asked about that. Security can be a big challenge, and it sounds like you have some some comments on that as well?
Absolutely. It's important for people to follow GDPR, to follow HIPAA, to follow high trust standards. Assuming that's the case, I think the biggest risk is bad patient care. And as a therapist myself, a death is an outcome, or a homicide, or some egregious event that occur as a result of a mental health condition. So I think that's absolutely the biggest worry I have, and I think it's present day. It's not a theoretical worry. There are many opportunities for patients to receive bad care through apps right now, so it's very important that is evidence-based care that occurs and not given by an unlicensed clinician, not given by a job coach or given by someone who really wants to give advice, but rather somebody who has training and education, and there's a monitoring body that's assuring that this is good care.
Right, exactly.
I think that's exactly right. And the area where it seems like we have only upside is actually using software to deliver what we know is actually best practice standard of care. And I think if we step back and are honest with ourselves, we actually fairly routinely fail to deliver guidelines-based best practice care. So the word standard of care, I think, maybe covers a lot of sins. What we do routinely is perhaps not what we ought to do. And that kind of deterministic software seems to me to be the really safe spot where it's all upside. I'm not sure that's what we mean when we say AI. I think that's probably something more in the digital care transformation space, kind of offloading executive function. The probabilistic data-driven software that I think we more conventionally think of as AI, there's obviously this long tail of privacy risk. And to your point, Sabine, I think that one of the mistakes we make there is not appreciating how long that tail is, right? The magic of digital is infinite perfect copies. As long as that data exists somewhere in the world, it has the capacity to be used for good stuff or bad stuff. And we actually can't really contemplate that full chain of future uses stretching out until the data ceases to be. So it's very hard to use a conventional risk-benefit analysis around these data sets. Maybe they're exceptional. I don't know. I'm sort of sympathetic to that superficially. I also know that the history of psychiatric exceptionalism hasn't always brought us to the best place, but it also seems sort of intuitively reasonable. I don't know, but I know we can't reason about a sort of infinite future use, and that's actually what we're confronting.
And I think building onto that, so that what we ought to do is one of the things we ought to do is more screenings, right? Right now we do an annual depression screening when you go in for your annual wellness visit. And even if you screen positively, you're not going to more regularly get screened as if you had high blood pressure, say. They're not going to, if you have high blood pressure as a patient, you're not going to just measure your blood pressure once a year, put you on medication, and then come back in 12 months, hopefully it's doing its thing. And I think this is where AI and technologies can start to play a component in enabling more coordinated care and integrated medicine, where it's not necessarily there is the therapeutic side of things, and you're the actual treatment, but I think the other side of the coin is being able to be a tool to coordinate care, especially remotely, and to do more longitudinal tracking and assessments so we understand how a patient is progressing through evidence-based treatment, and not just measuring it when it's convenient to measure it. And that leads to a risk. A lot of the health systems we work with, one of the big barriers that we have to overcome is their propensity to want to do the right thing, but to be risk adverse in doing that. And so just the other week, the question was posited to us, well, if we do more screenings, it's probable more people are going to screen positively. What do we do with them? It's like, okay, well, that is something we need to figure out.
The access problem.
That is something we need to figure out, but that's more reason that we need to do this, as opposed to just pretend that the problem isn't there.
Absolutely.
If I can, when we have these conversations, one of the things I always worry about is that there's a natural tendency to be worried about data security and privacy, and I think that's important. And I completely agree with Jennifer's comment, and the comments that are being made here is that we need we need to engage and rely on and test and validate that people are using best practices, that they are validated, that they are certified, et cetera. I also want to go back to Jennifer's comment is that we can't use these, though, as reasons not to engage in best practices or to seek care. Because what I worry about is that we're not, the genie in many respects is out of the bottle. And I'm not saying that in the context of sort of medicines. I'm saying that in the context of the world that we live in today. The cars that we drive, the phones that we carry, the digital footprint that we leave, not in the devices that we use, but in actually when we seek care, everything is tracked. It's tracking your electronic medical record, it's tracking your claim systems. I could be completely anonymized, and even though I think I'm anonymized, I could aggregate enough data around who you are, where you were, when you were there, et cetera, to recreate that information. And what I hope is, and I'm not speaking as a Novartian right now, as a Novartis employee, I'm speaking really as just a citizen like you and me. It's a terrible term that we use internally. But I think that as we advance public policy together, what we need to be thinking about is about proper use of data and less around being worried about some of these things because, again, as I said, the genie's out of the bottle. Now it's just making sure that people don't use it in a nefarious way, to your point.
Yeah, and I also have to say that the field is also trying to get a grip of that. There are, for example, there is now this website, it's called CyberGuide, that allows clinicians to see, how engaging an app is, how clear it is in terms of the privacy statement that's delivered upfront, how much evidence-based there is. There's more and more people who are also seeking FDA approval for their app. I feel like at this point, I think the development of apps has kind of outpaced our thinking of security, but the field is trying to catch up, and I think we can all be responsible and be a part of that. I want to just get back to something that several of our audience members have now asked about. So several of you have asked about, okay, so if you use these AI-based tools and if you use these apps, what about the human element, and how do you sort of reconcile this with a live provider? How do the two of them go together? Does anybody want to comment on that?
I think solely AI-based tools, we've kind of shown over and over again that they work beautiful in clinical trial settings and they have very factual information when the patients are adhering or having incentives to a trial, but then in real life they don't engage, that we need that human component guiding that care. And there could be additional psychoeducational pieces, but solely AI, the engagement rates can be challenging.
Yes.
And we know that engagement in therapy in general, it can be difficult.
So what you're suggesting then is just an app or just an AI-based tool alone might not cut it, and many patients might not go back to it the next day.
It's what the research shows, yes, on average 14 seconds for some of the apps.
For 14 seconds, okay.
Yes, we patients, you have this great idea that you're going to go and you're going to practice this 1 hour every night, but the reality of life doesn't necessarily happen.
And how much clinician engagement then is needed for patients to stick with it? Do any of you want to comment on that? So if we need a little bit of that human touch, how much of that?
I think it depends on the severity of the patient's presentation, the longitudinal course of the condition, their ability to engage. Are there somebody who's highly anxious and could have traits to do very well to follow rules and do your homework and things like that? But for most people, I think a great deal of human interaction is truly necessary in order to get the individual better.
Yeah, and David, you wanted to comment on that as well?
Yeah, so there's the issue of engagement and being able to longitudinally have engagement, because most people drop off of most things, frankly, let alone apps and so forth. You mentioned a couple of times homework, and I think that's part of the issue as well. Is it's really important and evidence-based, but there are also modes of interaction that may be more user-friendly, require less executive function, which is or sustained motivation, which is something that is often lacking, in everyone, frankly, let alone people who need these. And I think the issue of clinical engagement also comes to the issue of scalability, and we don't want the perfect to be the enemy of the good. One of the great promises of these technologies is that they can scale at cost virtually to many people who otherwise wouldn't have the benefit. When you add the human component, that's better for all sorts of reasons, whether it's oversight, whether it's actual clinical engagement and decision-making and care, or constraining of the algorithms. But it's also the case that there may be certain things that are that can be beneficial, and there will probably be a range of these different things. One of the critical elements is that there's not enough clinician, let alone scientific involvement in a lot of the apps that are out there that call themselves mental health apps. And there's a slippery slope between mental health and wellness and calmness and relaxation and stress reduction, et cetera. And we need to decide as a field or be engaged in, as repeatedly is being said, sort of evidence-based, pathology-based, but also realize that there's a great need for prevention and stress reduction as well.
David, to ask you a follow-up question on that, just because I'm curious, the aspect of, are you saying that we could use AI to identify, to lack of a better term, triage patients, to say these patients need to see a person and be, and then...
I wasn't saying that, but that's a good thought. And okay. There are pluses and minuses, and there are dangers to that as well. I want to come back to a great point that you made, that we're here to talk about AI, and AI is sort of the magic in the black box behind, but we have to really get into the algorithms, the code, what the assumptions are, what the data sets are that are fed into it. And also your point, which I think is great, is that things that are digital that may not be AI may get us a fair amount of the way there. And just because AI is the sexy term right now, and of course has tremendous potential to take us to different sorts of places on different levels, doesn't mean that digitalizing what we know and can do and needs to be scaled isn't a really important component of successful work in this area.
Mm-hmm. So I just want to touch on you have one more comment.
Yeah.
Okay, go ahead.
If it's okay. So I think it's important to say on the one hand that I think we all can agree that digital technology should be a complement to human engagement. Mm-hmm. I also want to throw down the challenge, which is when my kids are playing Fortnite, no human being needs to reinforce the use of Fortnite, right? And so maybe the part of the challenge, and again, I'm not taking away the importance of actually the physician interaction or the care community interaction or our social network interaction, because I do think that those are important. Mm-hmm. But having been a serial entrepreneur, or still a serial entrepreneur, I think we need to look to ourselves and say, well, maybe what we call engaging apps really aren't engaging apps, mm-hmm. right? Being reminded to take your medication is not exactly the most exciting thing in the world, yeah. right? And so that's not what I consider engagement. Now, if we could think about therapeutic intervention models, right, that are truly engaging, that are best in class, we can hopefully move that pendulum, not in a negative way, but in a way where they are self-reinforcing. Mm-hmm. Again, not to take away from the importance of the physician interaction or the healthcare professional interaction, but maybe we should look at ourselves. Maybe we're not doing as good a job as we think we are in designing these solutions.
Exactly. You make a very important point. So one of the ideas the panel has already mentioned, how to make the apps more engaging, is to add this human element. And I think you're going after something which I think is extremely important. We have to develop better tools going forward. And you hinted at perhaps we need to gamify them, right? Because you were bringing up the example of Fortnite. and any other ways in which we could make the tools that we have better? What's needed in the future?
It seems to me that the single most obvious thing is a massive change in efficacy. Mm-hmm. I'm from MGH. I often imagine what it must have been like to see that first public demonstration of ether. And so often I find myself in this space saying, oh, we need an RCT. What works? It's whatever has an RCT. But I would guess that the anecdote of the first etherized surgery, if you were sitting in the audience and you were the next patient, I imagine you were willing to sign up. Yeah. Yeah. Right? If you get a big enough effect size, it doesn't take that much of a trial.
Yeah.
And so this is a totally aspirational comment, but if it was good enough, people would do it.
I think you all make very important points. So I think what I'm hearing is that in the future, we need apps that are not only fun and engaging to use, but also apps that are relevant for patients and that are evidence-based as well, right? So that there are trials out there that show that these tools actually work. And that's a big challenge in the field right now. There are actually very few apps or AI tools that are evidence-based. We are still very much in the early stages. It's a very exciting field, but there's not so much research to support it yet. And what I always think about is in order to really make a dent, we ultimately need our patients to help us develop these tools. I think we want to engage different stakeholders right from the beginning. We need to work with patients to develop the next set of tools. And of course there's so many tools out there, especially the apps that have been developed without the input of any clinician at all, right? So many, I mean, they might be fun and engaging, but they have been developed without any clinician. They have been developed without anybody who was ever planning on testing them. So we need to get all of these different people together and to think through, okay, is this tool relevant? Is it based in science? And ultimately, we need to think even broader in terms of stakeholder engagement. And we need to even think about how will these tools ultimately fit in the larger healthcare field, right? Will insurance companies want to use this? How will we ultimately be able to bill for these tools? So right now, I feel like the field is still very fragmented, and there are some scientists who are making these tools, and then there are obviously a whole bunch of companies out there who are making these tools, and ultimately we would all benefit more from team science and a much more collaborative approach than what we are currently seeing. So I want to get back to some of our audience questions here because we are getting many of them, and they want to know what you think is next. What will we see in the future? What will happen, especially for serious mental illness going forward?
I think first step is making diagnostic accuracy better. It's not fantastic now, and a very qualified clinician compared to very qualified clinician might come up with different diagnoses. So first step is assessment of figuring out what the diagnosis. The next step are outcomes framework. So not just, I think the person is better, but over time, do we have objective ways to demonstrate that patient is better?
Mm-hmm. Assessment. Mm-hmm. Mm-hmm. Yeah, David?
We're thinking a lot about brain-based and brain-computer interface sort of approaches. And I think if you're asking about the future, the brain is the organ of the mind. The more we can both inform the apps, the AI, by brain relevant information, and the more we can potentially, if we're really talking about the future, feed back to the brain. There are pluses and minuses to that. There are different issues and so forth. But anywhere along that spectrum, I think that's going to be part of the future as well.
Mm-hmm.
I think an important piece is, and we're seeing this trend already with now collaborative care and integrated medicine being reimbursed by CMS and a lot of commercial payers, and a lot of hospitals are integrating LCSWs or behavioral health specialists into primary care settings and other physical health settings. We're going to start to see this trend where rather than get your physical health treated over here with whatever OBGYN for if you're a woman in pregnancy, or pain management specialist or primary care, and then, you have depression or anxiety, go get your mental health treated over here. It's just going to become health. Mm-hmm. And because one affects the other, we know that more than, and we understand that, and I think we're acknowledging that now more than ever. So I think as we move towards the future, the discussion around anxiety and depression, and as a patient when I'm going through, if I'm about to get surgery and I'm pre-op and post-op, understanding that that's an anxiety-inducing event for anyone. And if I can get a handle on that anxiety, that it will lead to better health outcomes overall. And technology can be a piece of that solution. I think that's a key component of where we're going in the future. And it's the way it should be.
Mm-hmm. Right. So our audience members want to know who will ultimately use these tools? Do you think that these tools will only be used by younger individuals, or who will apply and take these tools and take advantage of what's out there? Yes, Jennifer.
Sure. I think that therapists, to start, can be quite helpful in using these tools to hone their skills. They can't go and read all the literature on a specific presenting problem, but if they can gather all the knowledge through AI and that's fed to them through to messages actually during their therapy sessions, and whether it's recorded or it's a written transcript of therapy that's happening via an app, that they receive live guidance and advice. And then they also receive teaching and training modules to make them better therapists. We don't know the magic sauce of how to make mental health patients better from a therapy context. There isn't magic. It's good clinicians that can be helpful in engaging the patients and providing the correct kind of care. So if we can empower therapists to have all the tools that they need to provide that care in the moment to the patient, they can provide that care and the patients can succeed.
It's really interesting. Age has for many years sort of always been the second question that people ask. The first question is usually around data security and privacy. And the second question is, well, my grandmother or my mother would never use technology. And the reality is that's just simply not true anymore. It's not true across the board. I mean, we could use example after example. Facebook started out predominantly as being, something that the 20 and 30 somethings used, and now the vast majority of people on Facebook tend to be actually 65 and older. The vast majority of older people are using Uber, smartphones, etc. It's not about technology or age. It's actually about sitting and helping the individual. What you see in terms of age is actually a variation in terms of how they engage technology. And so they won't necessarily experiment with large numbers of technology. They won't necessarily, but they will actually engage with a few very helpful value-adding technologies, Facebook, Uber, et cetera, things that they find relevant, many times where they have been helped or coached. And so, I respect the question because I think it's 100% the right question, but I always challenge that question because it's sort of framed in the wrong way. It should be framed in the context of how do we make it accessible to everyone? Yeah. And we should make these, if they are best-in-class approaches, we have to think about how do we make it accessible.
Yeah, I agree. People use it because it's useful to them. If we find that there's some sociodemographic predictor of usage and the utility of the intervention is not similarly stratified, it means we have an onboarding problem. We're just not making a good enough product.
Yeah.
And these points raise the issue too of, do we engage with the big companies who have already created the big social networks and that people are already engaged with? There's downside that we know well, some of which I was just hearing on the radio on the way over of the latest version. But in a way, that's an ecosystem that's already there. People are using it because it's beneficial to them for other reasons. And while we're talking a lot about experts and clinicians and so forth, I think another trend is, peer support in mental illness, or just peer support in general, whether a person has multiple sclerosis, whether it's college kids on a campus and depression and suicidality, whatever it is, the more organic and natural and well-meaning number of eyes or interactions there are, if you map that out, even in terms of complex systems and network theory, the more protection you have, and again, it can be done in a way that is appropriate and has safeguards built in. And so I think another trend is that we're going to be seeing more, hopefully, of that as well.
I'm glad that you brought this up because we have a number of questions that ask about the different kind of tools that are currently out there. We talked a lot about the apps. We talked about the peer support, and I'm not even sure if everybody in the audience would actually know exactly what that is. Can you maybe explain that, and then maybe we talk about other tools that are available as well?
AA, for alcohol addiction is probably the best example of people getting together with like experiences, similar challenges to, either bear witness to each other and or support each other or share grief or whatever. And it turns out that that's a fundamental human sociobiological set of interactions that is inherently rewarding and has healing elements as well. And so we're seeing now more and more that peer counseling, if you will, for patients with schizophrenia or bipolar disorder, higher functioning, or depression or asthma, whatever it is, or people who are going through something in the world that's non-medical, is incredibly powerful. So harnessing, again, with best practices and with safeguards and maybe AI triggers built in to bump it up to the next level of scrutiny or response, and with appropriate safeguards, can both serve a monitoring as well as a supporting real-world effect, and scales much more than we could ever do, and is more natural and likely to be accepted.
Thank you. So we have the apps that we talked about a lot. We have peer support. What other tools can you think of that might ultimately be helpful to our patients?
I could speak specifically from our experience at Neuroflow. I mean, there's care coordination tools out there that help enable collaborative care and integrated medicine. Attach right into the EHR so that you don't have to have dashboard fatigue, and when a patient is identified to have a certain mental health illness, depression, or anxiety, or be at risk for those, to then conduct that warm handoff to LCSW or behavioral health specialist. And then feed that data back to the MD and the care team that, after the engagement with the LCSW or PhD, what have you, the behavioral health specialist, and to allow that collaborative care model to thrive and to be done at scale. And there's a ton of technology now and tools out there that enable to do that. Right. AI can be a component in that, but it's not the, it's not the entire piece.
Right. Other tools.
I think there are sort of two classes of mostly hospital-based software that I'm excited about. One is probabilistic risk stratification. So here is a finite resource. Here's our pool of intensive case managers. Let's risk stratify our population to identify the group of people we think are most likely to benefit. So that's just making best use of finite resources within a fixed system. The other is really, to your point, kind of rule-based care around maximizing our capacity once we've recognized a person of a certain kind. So routinizing care and providing software that helps successfully guide a patient down that care pathway. And in my mind, that's really deterministic, acceptable or appropriate use criteria. Most importantly, thereafter, followed by appropriate response criteria. I think where we get into trouble often in psychiatry is we'll recognize the problem, we'll pick an appropriate response or an appropriate treatment. We'll realize that actually partial response is a not uncommon terminal state, and so we'll settle for partial response, and not actually keep pushing that ball down the care pathway. And so I think, again, sort of two sets of divergent software, one probabilistic around risk stratification, another much more deterministic around appropriate use, appropriate response criteria and care pathway.
Maybe just building on what Tom said, if we use technology and AI to better risk stratify, to better sort of lead us towards clinical decision making, hopefully during those 8 minutes or 20 minutes that we have with the patient, we could actually recapture back as much of that time to actually do the actual care that we're hoping to do, right? Yeah. So instead of asking some of the simple questions and trying to figure out and do the initial diagnosis, now we can reclaim that time to actually provide care. And that's happening not just in the actual intervention model. There are some great companies, just to name one, there's a company called Accolade that sits in a really weird place. So when you call your insurer and you ask a set of questions like, can I get reimbursed for, or where do I go for, most of the time we eschew making those phone calls. Mm-hmm. But what Accolade recognized is that What they wanted to do is they wanted to use technology to actually make those calls actually much more meaningful. And instead of basically saying, you called for point A and I'm going to give you a response to point A, what I'm actually going to do is I have a unique opportunity because you're on the phone. And so I'm going to answer you on A, but what I'm going to do is I'm going to figure out, do you actually need, or are you actually calling because there's B, C, and D, right? And so, and in fact, what they found is that if they spend more time with the patient, not less, more time with the patient, they actually avoid further healthcare costs and they direct the patient in more meaningful ways. And this plays to the whole notion of social determinants of health, but they completely looked left instead of right. And they said, what can we do differently in this engagement model? And it's a brilliant way, again, of combining basically AI to make that intervention more efficient in the upfront, but then the human touch to make it better in the long run.
That's really interesting. So that sounds like, I think oftentimes we end up in this fear, oh, what if AI is successful and then I'm unemployed? It's like, well, I don't know, that might not be so bad. We'd find something else to do. It sounds like they jumped right to let's figure out the next thing to do. I like that.
So speaking about human touch, I mean, the telepsychiatry and video psychiatry we haven't really talked about because we were thinking about apps and so on. But the use of technology and potentially even the incorporation of AI into asynchronous or actually now synchronous spatiotemporal treatment modification of how and where we interact with the patient is something that can really be helpful as well. You started the whole session by talking about parking and everything else and so on. Plus, childcare, life, etc. And so the ability to take care of patients with versions of telepsychiatry is going to be, really needs to spread more than it has, and there are going to be solutions that make it easier. It may also be that it'll change or should change the way in which we practice or get reimbursed. Maybe for a certain kind of patient, if I can speak with her for 5 minutes every other day, that's better than speaking with her for 20 minutes once a week or once every 2 weeks. If I can check in, how's it going? What's the issue today? How can we practice this different way of seeing things? Do we need to change your dose? So there's that as well.
Okay, so we have a number of questions that focus on what does AI do for us right now? The audience seems to think that we are focused very much on what will happen in the future, but are there any clear benefits that we are seeing already at this point in time? Yes, Jennifer?
I'm happy to share this, a company that does AI right now in real life, providing clinical decision support. So diagnosis prediction, it's actually better than humans, which is disappointing, but it is better than humans. Provides predicted severity level, provides the likelihood of dropping out of therapy. So if we think of what are our challenges, we have to have good diagnosis, we want to keep them engaged, we want to provide that good care in a reasonable amount of time. There's also clinical decision support that's live that says, are you practicing fidelity to a certain therapeutic model? So a CBT, for example, because we know that correlates with better patient outcomes, better engagement.
Right, that's really helpful. And our audience also wants to know, what about severe mental illness? Or can you think of any tools that would be helpful right now for patients with severe mental illness? Yes, David.
Yeah. Can I start with something back to the last point as well? As a researcher, I'm most excited about AI right now for what it can help us learn. If we're collecting more than 1 million data points per day per person, there's a ton in there of patterns, of associations, of potentially clinically relevant or predictive data that we don't know at this point. And so while today may not be for the app yet, to inform the apps of the future, how we identify the signal in that noise or the associations and correlation matrices that are relevant for these things are going to be important. To the issue of serious mental illness, it sort of gets to another issue. You know, in psychiatry, we tend to think of mood and behavior as well, and split off cognition a little bit. And we think maybe, oh, if this was a panel on Alzheimer's, we'd be talking about cognition and so forth. But there's huge incidence of dementia and so forth, but B, and traumatic brain injury, but which also has psychiatric sequelae. But B, many of the psychiatric disorders have cognitive dysfunction associated with them that we don't address and don't think about enough, and that in terms of neural mechanisms and in terms of disability end up being huge drivers. And I think that one of the areas that therefore we haven't talked about, and to your question would be relevant for the more severely mentally ill, particularly patients with schizophrenia, and there's a fair incidence in bipolar as well, and certain kinds in depression, are aspects of cognitive dysfunction. I've often thought that sometimes what we do best is to be the frontal lobes for our patients when their frontal lobes are not working. And I think the more we can sort of support executive function, quite aside from memory and organization, I think we'll be doing our patients and their families a great service. And I think so that's a whole sphere where for the more severely mentally ill, they may need some support that's user-friendly, that's right with them, that helps them stay on track and achieve their goals better or adherence better.
Very good. Okay, Weston.
Just to quickly add to that, and also to be in the right moment at the right time. If you think of somebody with substance abuse, has a GPS on their phone, and they're getting close to the liquor store, data to say, would you like to engage in relaxation exercise? Would you like to try these particular strategies? Somebody with agoraphobia, and they're going to the mall, and to trigger some meditation or trigger some type of that in the moment. We've definitely had experiences. I had an experience actually with a patient last week. One of my clinicians was telling me that she was in the car with somebody an uncle who had molested her on the way to a funeral, and she was actually able to, in real time, engage in relaxation strategies because she knew she wanted to be part of the funeral. This person was here, and she would not have been able to survive that experience. She likely would have been hospitalized after that. And
it comes back to social as well. Often with addictions, as you know, if you have something on a phone and there are a certain group of friends that a person uses with, then the most difficult thing is to disengage from that social network, and there may be ways and algorithms that can help with that.
Yeah, we keep coming back to that, how enormously helpful AI might ultimately be with clinical decision making, and that could be by combining sensor data that we are collecting with the phone in terms of GPS, are you in your sort of high risk environment, but those data could of course also be combined with what's in the electronic medical record, for example, so that ultimately we are able to select the best intervention for our patients. But I want to talk a little bit more about what those different interventions even might look like. What we haven't talked about yet at all is things like chatbots or avatar therapists. Can you comment a little bit on that, and how we might maybe even think about matching those interventions to different patients, to patients with different levels of severity? So how, once we have all of that data for our patients, how do we best match them to what might be out there?
I think that chatbots are great for subclinical populations and those for low-lying, kind of worried well folks. They certainly can be helpful. We know that people respond positively to robots, to supportive emails in different studies, even though they're automatically generated. So yes, I think there's a place for that.
I mean, I think what you heard from Jennifer in the example she gave just now actually was an example of using I don't know if it's AI or predictive modeling around sort of making therapeutic suggestions. I mean, so the example of the getting close to a geolocation around a liquor store. In Reset and Reset-O, which is the available therapy for, or drug therapy, whichever you want, for substance use disorder or opiate addiction, AI is built into that engine, right? And so what we're trying to do is use best-in-class cognitive behavioral therapy, which is available in person, but also realizing that there are limitations to in-person meetings. And so if we can make it real time, if we could predict based on a knowledge of what those triggers are, of what your human behaviors are, of where you're likely or when you're likely to need a little bit of support, that's built into the system. And then understanding, again, as we begin to see reinforcement models, so behavioral motivations, substituting basically endorphin-generating events that you used to get through addiction, now giving them through other kinds of mechanisms. Spinning a wheel and getting a $5 coupon, it sounds silly, but that could actually avoid someone from actually, drinking or taking, a pill. And so, artificial intelligence is built into these therapies today. And so it's real. It's not just diagnostic. I mean, diagnostics, there are a lot of fantastic examples for diagnostics, but we're building them today into our interventions.
I think we have to be really careful with chatbots, though. I mean, I do think that there's something there for the worried well, but even with the worried well, if they're going through, I mean, there's tons of cases that you read about where someone will say, the chatbot will ask, how are you feeling today? And the person responds very, very bad and says, well, tell me more. And they'll respond, oh, my spouse is abusing me or something, I'm thinking about killing myself. And then the chatbot will respond with, well, I'm sorry to hear that, like, work on your breathing. And it's like, whoa, that is, and so I think that there's promise for them in the future, but we have to be careful today to help patients.
I think the place where we've had more luck with that is in weight loss, where we actually have a constrained vocabulary of possible responses, and what we're really doing is adapting a set of known adequate responses to a much more constrained input space. And so that adaptive reinforcement seems safer than a purely generative model right now.
This is a really important place. I mean, this is hard. Right?
Yeah.
I mean, when you talk to Amazon and you say to the Alexa folks, and you say, what's been the biggest problem in designing Alexa as a platform, right? And they'll tell you, we actually, where people spend the vast majority of time with Alexa? Trying to trick it, right? Trying to tell it jokes, trying to ask questions to figure out where it doesn't know, what are the boundaries of Alexa's intelligence. And your example is a really great example of this is hard, and it's not that person was trying to trick you. They were having a serious situation where the intelligence that was designed into that application just didn't contemplate that response, right? And hopefully over time, it doesn't mean we should eschew these technologies. Hopefully we understand what the existing boundaries are of those technologies. We accept them, and then we try to work to improve them, right? But we have to bring a little bit of that, we need to make them human. And right now technology, we call it artificial intelligence because it's still artificial, right? It's not human intelligence yet.
Yeah, I guess my point is, and building on what Tom said earlier with efficacy, if we're going to expect a chatbot to replace a human in any realm, we better be sure that they're actually a replacement, an adequate replacement, in any situation, especially in the healthcare context.
And
So a word of caution here,
Yeah.
it seems like, right?
They need to have good data going in, and you don't have that good, organized, clean data going in. I'll give the example of, we were training, we had the NLP going for risk assessment, and then they came to the US, and there was a UK clinician training somebody, and the person said, I'm getting my affairs in order, referencing suicide, and the UK clinician said, that's just wonderful, I'm glad to hear you're getting yourself organized. So I think that's a perfect example of a chat bot that you need to think about, what are the 100 possible ways you can say, how are you, for a mood check, and truly test these symptoms using clinicians.
And I think this gets into a really important issue of disparities, which we want to hopefully use these technologies to transcend. The data that you feed it is the data that gets crunched. And if we are not selecting or assessing or accessing underrepresented and underserved populations, then we're not going to get algorithms that spit out the right either assessment and or approach or workable approach in those settings. And so I think that as this field progresses, like anything else, we need to start to think about making sure that we build in an appropriately diverse and inclusive approach to the data as well as the algorithms.
I'm so glad that you just said that, because we have a whole number of questions about the socioeconomic divide and the treatment gap. And there are a bunch of questions wondering about whether we think that this gap will widen because of socioeconomic disparities, and not everybody might have access to a phone or to the internet, or will it close because of what technology, of the promise that technology might hold? I'd love for you to comment on that.
Well, I imagine it won't close by accident, but we can certainly work on it. And if you're talking about allocating a finite resource, it's harder to imagine that we're really going to allocate it uniformly despite our best efforts. When you have a much less scarce resource, the idea that we can attend to this as an inherently sort of meritorious goal and ultimately distribute it uniformly, that seems totally obtainable with effort.
And I might add that the reimbursement structure, thinking about, well, commercial could be more flexible in their choosing to reimburse different things, versus a Medicaid might be more strict to consider being more diverse in what they consider care.
So there are two very important points. So what you're all saying is, if we want to make sure that we are closing this treatment gap for everybody, right, not just for the wealthy, we have to think about this now, and we have to make sure that in our trials we include diverse populations. But we also have to think about it from all angles, right, including the reimbursement angle. Do you want to talk a little bit about that? Because that hasn't come up so much. How is technology reimbursed right now? For example, if you have an app-based treatment or any kind of technology-based treatment, what's the current reimbursement structure?
That's a great question. It's gotten better and better, I think, since I first began in the telehealth industry. So there's supposed to be parity for most states for telehealth care. Care with Medicaid, they require an audio-visual interaction, so an app would not qualify, or care via written conversation would not qualify. So there's definitely a variety, and thus creating these disparities, unfortunately, that somebody with Blue Cross in Massachusetts can receive that care, get their 10 visits, versus somebody with Medicaid might not be able to see their qualified therapist, which is pretty obvious where those disparities come from. So I think it's important to think of those disparities.
So on the positive side, what we're hopefully seeing is technology and reimbursement could hopefully actually become a democratization tool, not necessarily a disparity tool. So in Medicaid, some of the more forward-thinking states are actually giving cell phones to those people who have Medicaid. The biggest challenge that Medicaid patients typically have is that access. Right? I can't reach you. They tend to be homeless. They tend to actually have mental health disorder. What would be the single smartest thing that I could potentially do is I could give you a smartphone with unlimited, basically, coverage. Why? Because I want you to have the tools in your hands, the tools that we've been talking about today, to give you access: diagnostic tools, supporting tools, community tools, intervention tools, et cetera. And so what's the cost of that? Well, the cost is it the cost of giving that person the $500 or $1,000 phone plus $50 per month access, or is it the $10,000 or worse, $50,000 that they incur twice a month when they go into the ER? Right? So being smart about our programs is the first start, and a lot of Medicaid states are actually being smart and wise about it. On the reimbursement side, what we're seeing in telehealth, and actually not just in telehealth, but actually in just thinking about care outside of the clinical office, is we're seeing a reimbursement paradigm. The CMS has come out with a number of new codes that are actually reimbursing for what we're calling broadly telemedicine, but it can be simply just looking at someone's dashboard in terms of data that we're collecting from them at the home. It could be looking at some of these tools. So the good thing is that we're thinking about it, and I actually am optimistic that we're going to see a democratization, that these tools are actually going to give access and care and best-in-class care, because we're actually removing, in some cases, the subjectivity of the healthcare system broadly, and replacing that with hopefully better tools. So I'm positive.
Yeah. And I think we probably have time for one more question. So what is the regulatory environment for smartphone apps and other AI-enabled technologies?
Well, I think that's the million-dollar question. There's the mobile medical application landscape, and and the clinical decision support. Those are the nomenclatures by the FDA. I mean, you have everything from digital therapeutics, which are regulated just the same way that you would have drugs, 510K pathways, those sort of things. And then you have the consumer apps like the Headspaces of the world that aren't quote-unquote prescribed by doctors, MDs, that anyone can get access to, and then you have everything in between. But I think it comes down to the question of efficacy and claims and messaging the right thing to the patients. If you give something to a patient and say, this is going to treat your depression, it should go through that regulatory pathway to back up that claim.
Like the FDA pathway?
Right, exactly. I mean, I think it all comes down to claims and what the tool is supposed to do.
Okay.
If it's just supposed to help a provider's workflow to connect the patient, I mean, that doesn't need to be regulated like a digital drug or therapeutic would have to be.
I mean, to the credit of Scott Gottlieb, and he's retiring, but I mean, he opened up digital therapeutics to, I think, in a way that the FDA has struggled to be accessible. And he's accelerated that process in a number of ways. I'm not saying that it's perfect or that he alone did it. But again, I think on an optimistic level, I think that the FDA that we engage with today is a completely different FDA than we engaged in the past. And it's exciting. People used to develop these apps intentionally not to bring them to regulated processes because it was too hard. Right? And we couldn't get the evidence that we needed in order for physicians, smarter people than me, like you guys, to be able to actually offer those as care models. And hopefully now people aren't going to eschew that, they're actually going to embrace it. So.
Anyway, well, these are very exciting times, so thank you all for your wonderful questions, and many thanks to our panel for your thoughtful responses. So thank you very much.